Welcome to this edition of Go Vote Omaha, presented by the League of Women Voters of Greater Omaha. My name is Krystal Fox, Co-Director of Social Policy for the League of Women Voters Nebraska, and your host for today's program. Today we are talking to Dr. Dworak, who practices family medicine at One World. The League of Women Voters is a nonpartisan organization and does not endorse political candidates or parties. The League does, however, take positions on issues. Our purpose is to empower voters and defend democracy. Go Vote Omaha primarily focuses on policy issues, and as a result of our discussions, we hope you feel ready to make informed decisions at election time. In the spring, the Nebraska legislature passed LB 574, a bill that includes the Let Them Grow Act, which puts restrictions on gender-affirming care, and the Preborn Child Protection Act, which bans abortion at 12 weeks. While both are considered controversial topics, the first, gender-affirming care, is one that the public may not know much about or even have heard of before last year. Today, we are again joined by Dr. Dworak, MD practicing in family medicine at One World Community Health Centers to help us better understand this healthcare and the new law around it. Thanks so much for being here.
My pleasure.
To begin, I'm gonna ask you to introduce yourself and maybe the work that One World does and you do specifically there.
Okay. Well, and again, it's a pleasure to be here. One World focuses on quality healthcare with special attention to the underserved. And for as long as I've been there, and actually longer than I've been there, they've been focusing on outreach to underserved communities, immigrants, non-English speaking families, and have since expanded that mission with the golden thread of care for the underserved through efforts to increase mental health care, including therapy services, psychiatry services. We have been providing treatment for opioid use disorders with Suboxone for several years now, which is a direct response to what my colleagues and I saw with the beginnings of the opioid epidemic at the start of my career. I had Purdue Pharma drug reps extolling the virtues of OxyContin when I was an intern and had a bad feeling about it, but had no idea how bad that actually was. We also provide care to refugees. We focus on providing care to children, whether or not they have insurance. We provide HIV prevention services and universal testing. We have been curing hepatitis C for several years there and have been contributing as best we can to Nebraska's Hepatitis Elimination Coalition Task Force and the overall goal of eradicating hepatitis C from the entire state of Nebraska. We partner with many very valuable community organizations to provide cancer screenings, including breast cancer, colon cancer. We offer vaccines for disease prevention. We were on the front lines in South Omaha next to several meatpacking plants when COVID was at its worst, and began providing vaccines, as well as were an early site that started providing Paxlovid and other treatments, as well as coordinating with Nebraska Medicine to get people monoclonal antibody infusions back when those were effective against the strains circulating at that time, and have basically just been doing everything we can to make sure that we're playing our role as part of the safety net and providing high quality care to everyone who needs us. And not saying that, well, this care should just be good enough because that's all these people can afford. And comment on who those people are obviously could go for a long time. But to provide outstanding care to everybody who comes through our doors and to have a very high standard regardless of whether somebody is wealthy or not.
Thank you for sharing that. Yes, that's the mission of One World is really important to our community and integral to making sure that healthcare is accessible. So today we're talking about gender-affirming healthcare. And for those who don't know, could you maybe provide a simple definition of what that is and some examples of kind of what that means?
Certainly. So gender-affirming care is medical care in support of someone pursuing their expression of their gender identity. And although it most commonly comes across as care of trans and non-binary people, if we step back and think about it, lots of care is gender-affirming for cisgender people or people who aren't trans. Cis and trans come from some chemistry roots where cis is the same as and trans is crossing over to the other side molecularly. Socially, it's when someone identifies with a gender that's insistent, consistent, persistent, and deeply held for them. So a lot of people will transition socially, which may include how they dress, how they pitch their voice, how they style their hair. You may notice that I have hair that's not maybe the typical masculine norm, and for me that's just me. It's not because I'm trans. And it can be simple things like that. It can also include people pursuing medical services. This would often include hormone therapy, which would either be testosterone or estrogen and testosterone blockade, depending on the hormone somebody was born with and what their goals are. It can also include some surgical interventions, which are nearly universally in adults. It can include fertility planning, which is something that we also take care of for a lot of non-trans people. And just like the other things that we do, it is an area of that's profoundly underserved. We were talking a bit before the cameras were rolling that I got no education at all about the care of transgender people, or even really much education that trans people existed. When I was in training here in Nebraska, I've lived here almost my entire life, we had one lecture from one of my mentors in HIV medicine, a world-renowned luminary named Dr. Swindles. She had two of her patients living with HIV come to talk to us for an hour, and they both happened to be gay. And so that was the extent of my LGBT education that I remember from my training.
So some of the examples you listed don't necessarily have to be connected with a trans experience, is that?
Absolutely. Many of these things are universal. We use hormonal birth control either for family planning or to regulate periods, especially painful and disruptive periods. For cis women, some of these same agents are used for fertility for people of any gender. We have middle-aged men like me who may have low testosterone and who will need testosterone replacement therapy. It's the exact same medicines that we would use in any of these situations. And for youth, where if they are carefully selected and at an appropriate developmental and physiologic age, when we use blockers to pause the effects of puberty, to allow more time for therapy, further discussion, and support of the child, that's the exact same medicine that's been FDA approved for quite some time for treatment of central precocious puberty, which is approved for children down to the age of 2 if they start showing signs of puberty too soon. Where we're also stopping undesirable physical changes that will cause harm to mental health because they're developing out of sync with the child's identity and their chronologic age. So again, these are not medicines that are different than what we use in other aspects of medicine.
Thank you. So when we think of gender-affirming care, who are the people generally receiving that kind of care? Knowing that even that every person is different, who are you working with generally?
Just like with all of my patients, I'm working with as many people as I am able to provide this care. Obviously, there'll be a pronounced selection bias because people who do not need or desire medical intervention aren't going to make an appointment with me typically. I do have some people who come to us because we are affirming and welcoming, even though they don't need gender services. Members of the lesbian, gay, and bi community, and sadly, it stands out when a clinic is welcoming, and people can't always count on that. It's very well known in the medical literature that any member of the queer community may have had adverse experiences trying to access care. That's especially pronounced for trans people, but this can range from being denied care to being addressed incorrectly to being harassed or even verbally and physically assaulted in rare cases. And that shouldn't ever be something that happens to anyone, but it's, again, a known phenomenon in the literature.
So because of where you're placed in the community and kind of what One World's reputation is, you see people who are needing this care a little bit at a higher rate. Is that kind of what, or what is?
I don't think I'd say that. I mean, we see people at a higher rate because many clinics don't see them at all.
Okay.
So as with a lot of other things, we're accessible. People in the queer community and trans people especially are more likely to be uninsured.
Okay.
And because of the way our healthcare system in our country is set up, that we're needed, but that's why a lot of cisgender people need us too, for things like diabetes and high blood pressure management and all other aspects of primary care. Trans people need primary care too, so we are not solely focused on gender care. We're also doing age-appropriate cancer screenings for the organs that people have. We're providing counseling on exercise. I love nerding out about lifting and running programming with my patients, and I'll occasionally show them a picture of some of the lifting competitions I've done because I'm trying to practice what I preach. And we're seeing Spanish speakers and English speakers, which is normal for what we do anyway. If you speak Spanish and we've got subtitles, we could start talking in Spanish. So, okay.
Okay.
And
my Spanish is very bad.
Okay. But again, we're just like with everything else that we do, we're trying to be there for everybody who needs us. And we say all are welcome and we want to mean it.
That's awesome. So thinking about who can receive care, what does that look like? Is this healthcare available for anyone to utilize?
So that's a great question. It's evolved a bit over time. There are several editions that have happened of the World Professional Association for Transgender Health Standards of Care, or WPATH. The 8th edition came out during the pandemic. I believe it was the 5th or the 6th edition that Dr. Swindles stuck in my face when she had one of her patients that needed help with her blood pressure. Being a primary care doctor and working with infectious disease doctors at the HIV clinic, which is another thing I've done for about 10 years now, she had somebody where that was what they needed. She happened to be a black transgender woman who also smoked and had high blood pressure and had HIV. And sadly, that tracks that that's the first person whose hormone care I would own, because social determinants of health are real. And it's not an accident that all those things were happening to this woman in her body and her position in our society.
Yeah.
So, and her hormones were stable, her HIV medicine was going along fine, and her blood pressure was out of control. So I thought, okay, blood pressure, that's what I do, I'm good at that. HIV, I've gotten a lot of training, and it's just, are you taking your HIV medicine? Awesome, keep doing that. But I had no training on hormone medicine whatsoever, none. And so I asked Dr. Swindles, well, wait, don't we have to send her to endocrine for that? And she looked at me with that look that I had gotten more than once from her. Come on, Alex. And she handed me the guidelines and said, read these. She's already got her hormones, just fix her blood pressure and be there for her. And so I went in and sat down with her. I later learned, as I dug back further and further in her chart, had actually seen somebody that I knew from my training who had loudly dead-named her, or used the name that she was given at birth that she asked him not to use, and he kept using it. Misgendered her, using the wrong salutation, using the wrong pronouns, started yelling at her, followed her out into the waiting room, continuing to yell at her, and then he diagnosed her with a personality disorder in his note when he signed it. So, because she was not happy at being treated that way. And then she sits down with me, another white man, and looking back, I think it's pretty incredible that she actually trusted me, given the interactions that she'd had. I think that my saving grace was that I had enough humility to realize that I wasn't going to be there to tell her what to do. I was going to be there to listen to her and to support her. And so I sat down and said, hey, I'm Dr. Dworak, what can I do for you? And Dr. Swindles asked me to help with your blood pressure. I have some ideas. And she trusted me, mostly because of Dr. Swindles and the rest of the staff at the clinic, I think, not because of me.
Yeah.
But I wound up getting along great with her. And later, she was taking estrogen pills, which have a little bit higher risk of clotting. And in the guidelines that I was reading, it's very clearly delineated that transdermal estrogen or patches have a lower risk of clotting. She was over 40, she was smoking. Patches made more sense, and so I tried to get them for her, and she happened to have Medicaid. The response I got was, Medicaid doesn't deal with anything trans. We won't cover that, that's, no. So, and I got really upset because one visit to the ER for a clot rule out, or even worse, having a clot and needing treatment or being hospitalized would cost a tremendous amount of money, and these medicines are extremely cheap, and it was obviously, this person's trans, therefore we're not going to cover them. So that's pro se discrimination, despite it being the standard of care and recommended. And Dr. Swindles told me later it wasn't until she saw how upset I got that she knew she made the right call trusting me with this patient. But again, so we'll see people across the age spectrum. Many people who are adults, coming back to those standards of care, adults are allowed to consent for their own health in the United States, at least at this time. And so we use an informed consent model. previous editions of the Standards of Care had recommended mental health counseling, but going back further and further, there was progressively more and more gatekeeping, where somebody would have to live in a certain role, dress a certain way, and this not only excludes non-binary people, where they may, again, it's going from one social role to, no, you have to fill this one before you can have your treatments, whatever those might be appropriate for you, but I don't fit in that box,
Right.
and you're just trying to put me from one box into another box. But there was also a need to have a variety of, or a certain number of therapy visits to prove to the therapist basically that you were trans enough, and that's cost prohibitive for many people, and so it's gone from a lot of that and a lot of external control of somebody's health to informed consent, where an adult, just like we would do for diabetes medicine or a gallbladder surgery or anything else, we can go in and consent for ourselves.
So that's a great segue into, like, for those under the age of majority,
Yes.
how do they manage this system, and what is the role of parents and guardians in that process? And then I also want us to think about, like, pre LB 574, and then maybe we'll kind of start moving into, like, what this care will look like as that law goes into effect.
I really appreciate the question and the chance to explain what actually happens. I think there is both misconception and active disinformation around this. So for people under the age of 19, in other states it's 18, but Nebraska's legal age of majority is 19. It's obviously arbitrary because right across the river in Iowa it's 18, but again, we do and always have and always will follow the law in our practice. People under the age of 19 who are seeking care can be thought of in terms of their medical interventions, both pre-puberty and post-puberty.
Okay.
But for everybody, care is never given without full parental consent. So just like any other medical intervention, if I do not have the express permission of any and all parents, legal guardians, guardian ad litem, or anybody who has a legal right to have an input into that child's medical care, if we don't have all that, we cannot and will not proceed with any prescriptions or interventions. This is not something contrary to what I have heard at times in the national media, where someone can sneak out from home, walk in and get some hormones, and then go back home without telling their parents. That's a gross distortion and has never been how this works. Our process is to sit down with the child and parents, if there's a separation where there's maybe a new step-parent, again, everybody who has a legal right to dictate or participate in that child's medical care must be in approval and has to give not just verbal consent, but written informed consent.
Okay.
So, and that's what we want.
Right.
I mean, I want to make sure that we are completely transparent, that we're explaining the pros and the cons, the risks and the benefits, what these medicines will do, what they will not do, reassessing at regular intervals how this child is doing, making sure that this is beneficial to them, whatever the intervention might be, and allowing the child and the parents to take the lead. My role is to be there to offer guidance, to give facts from the medical literature, and use my expertise and training and my connections, and then allow them to lead me and I support them.
Thank you. So yes, and so I guess we kind of have a foundation of what gender-affirming care looks like in Nebraska, and the rules and regulations and things that lead to gender-affirming care here for both people who need it for a trans experience, but also for a cis experience. So now that LB 574 has passed, what changes will we see, and what concerns do you have really about how that passage will affect gender-affirming care?
I have many concerns about how it has been affecting care, even as it's been discussed, and how it continues to affect care. But I'll say that from my day-to-day experience, it's pretty much identical.
Okay.
The new emergency regulations, which have a public comment, which is happening on November 28th in Lincoln at the Lancaster County Event Center from 7 a.m. to 7 p.m. I'm planning to be there in the morning, and I hope lots of people turn up to make their voices heard and help our participatory democracy be just that.
I love it.
These regulations mandate that on the medical side, we have full written informed consent. Great, we were already doing that. That we make sure that all parents and legal guardians are involved. Okay, great, we're already doing that. that we talk about fertility, which is an important concern. Some people desperately want children. Other people desperately never want to have children. Many people don't know, and their thoughts might change. I was already mentioning a fertility specialist colleague by name every single visit, especially with children, but also with adults, even people who'd been on treatment for many years. I didn't want to make assumptions.
Right.
And so I'd say, hey, just so that you know, this specialist is here, and she and her group would be happy to see you. They actually make a special effort to work with the queer community, as well as other groups under duress, like people going through cancer treatment that could damage their fertility. And again, I've been pointing people that way, making sure that that resource is known to them and referring them whenever they're interested since I got started doing this several years ago. So, and so again,
So like
everything from a medical prescribing issue that I have been seeing in the emergency regulations, I was already doing that, and One World was already doing that.
Yeah.
There are a few specific words, there's some specific phrasing that needs to be used, which is not dissimilar to what happened when the state passed regulations on opioid prescribing, which, as I mentioned, is another topic that's very important to me. And again, it mandates checking the state's medication registry to make sure people aren't shopping around to different doctors for drugs, documenting written informed consent. And again, we were already doing all of that.
Right.
So really,
so that part
this
hasn't
is,
changed.
yes, the medical prescribing is really the standard of care that was already happening.
Okay.
So surgeries are completely banned.
Okay.
And that is something that there was one high profile case that I was not involved in, but again, I want the best for each person and hope for the best outcomes there. But I also know some other people socially where they've had procedures prior to this law going into effect where that's been marvelous for them. And the procedure that rarely happens for trans teenagers would be top surgery for people assigned female at birth who have significant breast development, which can be very distressing psychologically and socially. And the procedure is almost identical to gynecomastia surgery for a cisgender boy who has visible breasts and who could be very distressed by them.
Yeah.
I was a little fluffy as a child. I didn't never need any medical interventions, but kids can be really mean. And so again, it's basically the same surgery.
But is the boy, if the boy was having the surgery, is that banned now, or is it not?
No,
Okay.
Cisgender boys can still have almost the exact same procedure, and that is not regulated. Cisgender girls can go get breast implants, and that is not regulated. Circumcision can be done on pre-verbal infants who are completely unable to consent, and that is not regulated. Procedures on intersex people who have differences of sex development can be done when they are minors or, again, when they're babies for cosmetic purposes, which are inherently gender affirming. And there's a specific carve-out that says that those are not regulated by these guidelines, which is interesting to me because at the national conferences I attend to keep up my continuing education on this, there have been panels from intersex patients who have talked about the harm of having the facts hidden from them and of learning later in life that procedures were done to them without their knowledge and without their consent when they were younger than patients who are getting gender-affirming care, who can speak for themselves and who have identified who they are, and sometimes, again, even as infants, when they're definitionally incapable of consenting.
Wow. Okay.
So, and there's, again, the parallels are clear when you're looking at the whole spectrum of the LGBTQIA+ rainbow, and the logical inconsistencies really stand out to me as a physician.
Thank you. Thanks for sharing that. Yeah, that's really very interesting. So, like, I want to summarize just for my own learning. So thinking about what LB 574 has done, it's a very narrow set of regulations that really focuses on the trans community.
Only trans people, yes.
And so when you think of that, what challenges do you anticipate patients facing now? And are they exacerbated, or will it just kind of feel like more of the same, and how?
Oh no, things are worse.
Okay.
So things were already worse when this was being debated. I and other colleagues who are among the minority who provide this care and who have made ourselves known that we are trained and competent and glad to provide this care, we're already seeing people's mental health suffering. Younger children often weren't too aware. Teenagers and adolescents were quite aware. just like a lot of cisgender teenagers are quite aware of the dysfunction of our politics and other things. Parents have been, some of them terrified, all of them very much worried about this. Pretty much all of them have made plans on how they would either take their child out of Nebraska to a state where it's legal to get that care and try to stay here, or just leave Nebraska.
Wow.
I had the pleasure of meeting a family at a rally at the beginning of the year who spoke as the CEO of a nonprofit that helps feed the hungry. A very wonderful person, and the kind of family that we should be tripping over ourselves to attract more of here in Nebraska. That just, I mean, what more can you ask for than somebody who's dedicating their life to that kind of altruistic purpose, who happens to have a trans child? And he had said, I am going to leave Nebraska if I can't take care of my child. And nationwide, we're seeing internal medical refugees fleeing states that have banned this care if they can. Many people can't because they don't have enough money, because they have family ties, because there are other reasons. If somebody doesn't speak English, or if they're a person of color, that's a lot more likely that they don't have that mobility.
Right.
And so I view that as both unfounded in terms of the medical literature, because it's essentialist, it's denying the fact that trans people exist, and it's also discriminatory in other ways too, because it has, if the effects are differential in that way, that's definitionally discriminatory, and I don't agree with that.
Yeah. So if people could, or if you wanted people to learn one thing about gender-affirming care, what would that be?
That trans people need and deserve medical care just like everyone else, and that a threat to their autonomy is a threat to everyone's medical autonomy. And along those lines, in terms of other challenges we're seeing, there is a requirement that medications such as blockers or any injectable medicines, if I am reading it correctly, I went to medical school, not law school, need to be given in the prescriber's office. So. But many of these, so blockers are often specialty medicines that are extremely expensive and often are delivered to a specialty pharmacy. Doctors don't have those in our offices. But for safety reasons, we often don't have our staff inject things that we haven't had custody of, because we want to make sure that we're keeping control of it. So if I prescribe it, it goes to a specialty pharmacy, but then they can't bring it in, it's effectively not possible for them to receive that treatment.
Well, we learned a lot tonight, so thank you for speaking with us and joining our program, Dr. Dworak. For the League of Women Voters of Greater Omaha, I'm Krystal Fox, reminding you to inform yourself and be ready to vote. Go vote Omaha.